Morning, respected seniors. Now I welcome you all for the 15th morning CME session of our GP Association, and I request you all to stand up for doctor's prayer.
Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschid dukh bhag bhavet, na tvaham kamaye rajyam, na swargam na punarbhavam, kamaye dukh taptanam, praninam artinashanam. Please have a seat.
And I would like to invite Dr. Rajukethavath sir on the dais to continue the session and take the charge. Please.
So I am basically South Indian. Actually, I am basically Rajasthani. My grandmother is from Varanasi, so we settled in back. So my birth and brought up, which was from Hyderabad only. So I did my UG from in Kakatiya Medical College, which is located in Warangal. And after that, I did my MD Medicine and DM Neurology from PGH Chandigarh. So thank you, sir, and thank you for giving me this opportunity for presenting this most common and most common cause for second most common cause for mortality and the most common cause for disability. Which is a stroke management for compared to earlier, which is also very advanced in nowadays, and also which is a very vast subject. But mainly I am focusing on how do we thrombolysis and when do we thrombolysis and what is the time window period regarding this. So stroke is the main definition we define is acute neurological injury that occurs as a result of one of these pathology processes, either due to the most commonly two types, it is ischemic stroke and hemorrhagic stroke. Ischemic stroke is most commonly caused by either thrombosis or embolism or systemic hypoperfusion, and hemorrhagic stroke most commonly due to two types. One is intracerebral hemorrhage and other is subarachnoid hemorrhage. So in lifetime risk of stroke for adults, earlier we say stroke is in the older age population above 50 or above 60s, but nowadays even in younger patient, even second or third decade also we are getting this one. And lifetime risk of stroke for adults is in more than 25 years, it is more than 25%, and worldwide stroke is the second most common cause of mortality and disability, and case fatality rates from around 18 to 42%. Based on which type of stroke. In intracerebral hemorrhage, it is up to 80% also. So I am proceeding with one case and then discussing about it. A 60-year male, a known case of type 2 diabetes mellitus, hypertension, slurring of speech, and right hemiparesis, who's presented to a clinic within 3 hours of duration. So what is the next step? Because an etiology, pathology, these are vast subjects, so I am not discussing about that. I am mainly discussing about the management. So, if any patient will reach to our hospital, so we have to check these signs, most common signs. Either earlier we called it is FAST, like in the short form FAST, like facial weakness or any arm weakness or speech disturbance, then time. Which is a time earlier, which was time window period earlier is 3 hours, and nowadays we up to 4.5 hours, and even now with advanced system up to 24 hours. We can proceed with the thrombolysis or mechanical thrombectomy or any stenting like. So earlier we called this short form is FAST. Now two terms were added to the stroke symptoms. One is sudden onset any balance problem or sudden onset vision loss also. These two with and facial arm weakness and speech disturbance and within time. So common common symptoms and signs between the ischemic stroke and hemorrhage. Most commonly both are present with same symptoms, but some features are commonly seen in hemorrhagic stroke better than common than the ischemic stroke. So most common features is any patient presented with headache, vomiting, and deviation of head or eyes. In cerebral hemorrhage, if patient will most commonly seen in the frontal beats or anything or any basal ganglia bead. In this region, patient will present with deviation of eyes to Even patient, if in early coming to the hospital on examination, if his BP is high, and if we on general examination, if his high is deviated to the one side, then we are suspecting it most commonly lobar hemorrhage. In lobar hemorrhage, in frontal lobe, both are our eye signs. Eye sign is most important, in which eye is pushed both opposite to each one. If one side is bleed is occurred, then that side eye is deviated to the thus function is lost. So then eye is deviated to the same side. So by on clinical examination with higher BP, we may suspect he might have intracerebral hemorrhage due to the hypertension related. This is the common finding in everyday. Up to 60 to 70% patient we will find out this thing. And when patient presented with the acute stroke-like features with earlier clinic feature like fast or BFAST, then we have to get in our mind some differential diagnosis which may commonly present with stroke-like feature. In one of those nowadays we are seeing is in diabetic patient. In most of the patient, earlier any patient will come to the acute neurological deficit. First we have to check his sugar levels of the patient. Even most commonly in hypoglycemia or hyperglycemia patient, these common findings we will find out. After replacing the sugar levels with D25 or when anything, then patient will become normal. And out of this and some features like if in pregnant lady there is a posterior reversal bull encephalopathy syndrome and some functional, if a young patient presented with like feature, then functional deficit like conversion reaction, or CVT patient may present like this, and central nervous system tumors or abscess or any toxic or metabolic disturbance like exogenous drug intoxication and transient global amnesia and especially demyelinating disorder like multiple sclerosis and MOMAG patient, they may also present with like this. So when patient comes to us with clinical findings of focal neurological deficit, then we have to take rapid history because time is brain. Because window period, if patient anyone will comes to us, he will reach within the 4.5 hours. Then we find out the patient is having stroke, and on CT scan, if it is patient is not having intracerebral hemorrhage, then we proceed with the intravenous thrombolysis. Then we will save the patient further life, like in around 20 to 30% they may become totally normal, and in patients some because when they reach to our clinic they have a small infarct. If we delayed it may this infarct grows bigger and patient may in later life he become bedridden and disabilities like that. So time is the most important thing in the stroke management. So quick history, because in this thing we proceed with the intravenous thrombolysis. Some factors we have to keep in our mind, like if patient is having any oral anticoagulants or any history of any trauma or any history of history of hemorrhage or any history of or liver damage or any cancer medications or hematological disorders, and then we proceed with the airway breathing circulation. How is the patient? Then we have to look for NIHS, which is called National Institute of Health and Stroke Scale. Based on this, we divide the patient into mild or moderate or severe. In NHS 11 parameters will be there, like the same, the weakness, slurring of speech, what is the consciousness of patient, what is any sensory distinction between that. And then at the same time, when patient reaches to our clinic, we have to do the GI bus. At the same time, we have to send routine tests, because if patient within window period, even without looking this report like INR or RFTs, also we can proceed with the thrombolysis. But sometimes patient may worsen. So for the diagnostic purpose, we have to send at the time when we remove the sample. At the time, we have to send this routine investigation also. So now patient is came to our clinic with this focal neurological deficit. Then most common cheese is time. Time is the most common factor in this. If it is patient is reached to our hospital if more than 24 hours, this is out of window period. So there is in those patients we have to do just conservative management with the dual antiplatelets, or if patient has any cardioembolic disorder, then anticoagulant. If it is patient less than 4.5 hours or 4.5 to 24 hours, these things are most important. If the patient reaches to us within less than 4.5 hours, so immediate we have to do his this basic routine, and then we have to proceed with the CT scan. If a CT scan shows there is no hemorrhage, then we have to proceed with in CT scan if it is hypodensity is present or not. Based on that, if patient is severe neurological deficit, then we have to proceed with the at that time we're doing the CT scan, at the same time NCCT head with CT angio. These are most important, because in 4.5 hours, patient reaches to us, we have given injection, which is a cost around one injection is 30,000, and in all place it is 70,000. Then patient will ask, you have given injection, but patient is not improving. Then we have, in those situations, CT angio is important, because with thrombolysis, it is a large vessel occlusion, like carotid artery, primary branches of M1, M2 branches of middle cerebral artery. In those things, thrombolysis is not much works, because if it is a smaller vessel occlusion is there, then it will be open, 100% opening chances is there. But with large vessel occlusion, in those patients, there is a chances of complete opening of that vessel is very less. So in those cases, we have to proceed with the NCCT head plus CT angio, which is most important, because if patient is researched within 4.5 hours, we have to give the we have to proceed with the intravenous thrombolysis. During this time, we have to some exclusion criteria. This inclusion criteria is patient presented with focal neurological deficit within 4.5 hours and more than 18 years. Because in younger age, the stroke is very less, and not properly, any studies was also done below 12 years, especially below 12 years. So, especially these intravenous thrombolysis these things were mainly studied on above 18 years patients. So, basically, we have to consider with that also. Then, after that, we have to proceed with some exclusion criteria. If a patient came with neurology deficit, but after reaching to the hospital, patient may doesn't have the those symptoms. So this is called TIA, transient ischemic attack. In those patients, there no need to give intravenous thrombolysis. If we have checked the sugar, if patient is in hypoglycemia, after replacing the sugar, patient is become normal, then there is no chance. There is no chance to give intravenous thrombolysis. And if on CT scan patient is an intracerebral hemorrhage, then no need to give intravenous thrombolysis. A patient with prior history of intracerebral hemorrhage, then chances of bleeding is more. So in those patients also we usually don't give the intravenous thrombolysis. And like some patients, if any prior 2 weeks history of patient present with the GI bleeding or GI malignancy, or any prior history of intraaxial any malignancy, or any abscess, or if patient is in infective endocarditis related feature, in those patients we generally don't use intravenous thrombolysis in those patients. So a patient reaches to within 4.5 hours, we have given intravenous thrombolysis. What drugs we use, I will discuss in the next slide. Next slide. So, when patient reaches to clinic, then NCCT head is done to rule out. First, we have to rule out hemorrhage, or in fact, if hemorrhage is out of then if NCCT head and if there is a radiologist not available, then some features which may shows it is a ischemic stroke. Like in the NCCT head, some hypotension in the area of the brain, and some early signs like dense MCA sign and disappearing basal ganglia, insular ribbons, like this in this image, first image, I think it is blurry, which shows this is a dense MCA sign, in which middle cerebral artery, which is thrombosed, and which appears in the NCCT head like this, and sometimes it is density is milder. And by clinically, sometimes we call insular ribbon sign, in which if patient is having a left hemiparesis, in them we have to look for the left side. In left side, in basal ganglia region or internal capsular region, this is a insular region, in which this in the right side there is a prominence of sulci. Sulci and gyri are not prominent compared to the left side. This is sulci gyri. So this is called the insular ribbon sign. So these are early signs. So if patient we did thrombolysis and it's okay. If patient is more than 4.5 hours, then more than 4.5 hours, we have to do some advanced research investigations like CT perfusion scan. With CT angiography, we have to do CT perfusion scan, because 4.5 hours out of window period, there is a chances if we do intravenous thrombolysis, chances of bleeding is there. So in those patients, Even in those patients also, we have to do the thrombolysis. When if we do some CT, if available CT scan, then in which is CT perfusion scan is one of these things. In CT perfusion scan, patient is present to the clinic. Then if we do CT perfusion scan, this is the red one is the core. In acute presentation, patient present with some hemiparesis or mild weakness. But in surrounding this area, this green color and this orange color. So these areas, if any patient present to the earlier to us, he when reaches to the clinic, he firstly he has some mild weakness. After 24 hours or after 48 hours, he develop severe hemiparesis of 0/5 hours. The reason for that is because earlier he has only core, just a small infarct. Later it is developed the bigger, larger area. So for that purpose, CT perfusion is important. So in CT perfusion, it is core area which is already infarct, but surrounding the area, so which are called oligemia or penumbra, which are functionally not working at that time, but these are reversible tissues. In these patients, if we do thrombolysis or if a patient is having large vessel occlusion in them, we will do mechanical thrombectomy. So we may salvage this tissue, because due to this patient will recover with mild disability, just mild weakness or mild slurring of speech or mild facial weakness. Later he may become normal. But if we leave the patient like this, then patient develop a larger infarct and patient will become bedridden with contractures and aphasia like that. So recent advanced scanning in that CT perfusion is the one of the most common with NCCT, CT head, and with CT perfusion also we used to do. And at the same time, if it is advanced center, you have MRI availability. In the MRI also same thing, because in first image this is showing the insular infarct. This is in MRI we usually commonly see with diffusion restriction. Then with MRI perfusion scan, this area shows this much infarct. So this is core infarct, and the surrounding area is like penumbra. So because later this patient develops severe disability, for that prevention we have to do intravenous thrombolysis or mechanical thrombectomy. Like these scans also same. In diffusion scan, this small area is showing diffusion restriction, but in perfusion scan it shows bigger, larger areas. So in future the patient will develop severe disabilities. So because this is some historical aspect in which normally our brain tissue will get around 50 ml per 100 gram per minute blood supply. So if a blood supply is decreases, like if it is reaches to the zero or around below 7 ml per 100 gram per minute, then tissue will infarct will occur. So that is the time. So that's why time is the most important in the stroke patient. This is also same thing. So some must know questions in the acute stroke, like if his patient when reaches to the clinic, his patient has intracranial hemorrhage or stroke mimic. For that is a basic investigation NCCT will done. With that we can rule out the hemorrhage or infarct. And is a large vessel occluded, because large vessel occluded in that intravenous thrombolysis is not much help. So in those patients CT angio is necessary, NCCT head with CT angiography. Which is a part of the brain irreversibly injured, like penumbra, which is not infarcted, it is ischemic tissue with timely proceeding with the procedure like intravenous thrombolysis or mechanical thrombectomy. In those patients, the tissue will be reversible. Is an ischemic penumbra is present. So for this thing we have to do either availability of CT perfusion is there, then proceed with CT perfusion, or if it is MRI is available there, then MRI is the best choice. So routinely we have to do in acute stroke patient NCCT head with CT angio to look for large vessel occlusion and perfusion scan and MRI with these things. So time is brain. If patient is reached within the 4.5 hours, though in the stroke patient we usually use two medications. One is alteplase and another is tenecteplase. These are recombinant tissue plasminogen activator. In this alteplase, which is cost around 60 to 70,000, and tenecteplase, which is cost around 25 to 37 per one injection. In alteplase, we use 0.9 mg for kg body weight with maximum dose is 90 mg, which is given like 10% of this dose. If patient is 60 kg of weight, 16 to 9, so 54 milligram. In that 10%, like 5.4 milligram or 6 milligram we used to give over 10 minutes. Then after that, rest of the dose is over 1 hour. So when patient reaches to the us within at the time of 4.5 hours is window period, but patient reaches around 4 hours of window period. In those patients, the alteplase is not useful. There is chances of bleeding is there. So in those patients, we usually nowadays we are using tenecteplase. Tenecteplase more commonly used in the cardiac cases, but tenecteplase we are using in the stroke patient. In tenecteplase, 0.25 mg per kg body weight and the maximum dose is 25 mg. We can give it is bolus over the 5 to 6 seconds. So thrombolysis was done. If patient is out of window period, then what is the current practice guidelines? If patient selection in those patients, if patient more than 4.5 hours, then if patient present with this finding, then we have proceed with the CT angio or CT perfusion or MRI. If MRI available, then MRI perfusion. In those patients, if CT angio shows large vessel occlusion, even patient proceed with the 4.5 hours of within 4.5 hours of duration. In those patients also, if large vessel occlusion is there, then we have to proceed with the mechanical thrombectomy. In mechanical thrombectomy, like cardiologist will do like same puncture from the femoral and they proceed with the to the carotid artery, and from that we using sucker thrombus निकाल देते वहाँ से. So this thing can do will up to the 24 hours, because mainly is the core will be small, but large prevent from that, like penumbra. For prevention of larger, in fact, we used to do, well, routinely practicing is the mechanical thrombectomy. So mainly in stroke management issues, usually we thrombolyze or thrombolysis was not done, a patient is out of window period. So these questions will regularly getting in our mind. If how much fluids will give, if fluids give, then which one fluids is normal saline or half saline or DNS or RL, which one is better? In fluids we usually use is isotonic saline. Normal saline is the most important, unless of any patient is hypoglycemia or hypoglycemia in those things. So fluid is the most important thing. In normal saline is the best one in stroke patient. So based on the intake output, we proceed with the normal saline is the best one, because never use DNS or D25 unless patient hypoglycemia, because if hyperglycemia and hypoglycemia, those two in these two conditions, the infarct area will increase or infarct will increase, and then patient will land up in the severe morbid mode and this, because hypoglycemia is also called cell death in the nervous tissue, and hyperglycemia also leads to anaerobic metabolic acidosis and free radical release and severe damage to the already infected tissue. And next one thing is swallowing assessment. This is the most commonly we are encountering in our emergency patient, because patient when reaches to clinic, he earlier after 24 hours, after 40 hours, patient will become normal, or if he is mild infarct, he looks normal. He talks and he takes the water or food. But after that, so many patients develops this swallowing difficulties, because most commonly he is middle cerebral artery, which is located in the motor area. In that, our facial area, representing area is very larger. So even small infarct also patient will get this swallowing issue. So in those patients we usually do Gus score, in which patient is swallowing or not. Based on that, we better we proceed with the rise to be is the best thing in this patient, because due to this patient will develop aspiration pneumonia, and then patient will land up in the under comorbidities. And another thing we get is head and body position. In stroke patient, how you keep the patient the head and body position. Best position, if anyone patient, if cerebral blood flow will is maximum is when we get the supine position. In supine position, our blood flow to the brain is maximum. That is a good thing. But in these patients, there is a chances of aspiration pneumonia. These things are there. So though in this patient, at least we have to elevate the head inside at least 30 degrees. So that is the better for prevention of this aspiration related EE. And another thing is fever. This patient, in stroke patient, we usually get the fever patient, then we suspect, it might be central fever like that. But in stroke patient, up to 90-95% patient, they get fever due to the pneumonia and other, due to the urinary tract infection, these things. So, and also a maximum patient with the thrombophlebitis. After cannula, after we are putting within next 24 hours, patient will get thrombophlebitis. Due to that also, patient will get high grade fever. If it is central fever also, there is no special treatment for that. We usually give as paracetamol and tepid swanning, this thing. And next one thing is BP. This is the most common, and we usually get most common mistake with this BP thing. Because stroke has two types. One is ischemic stroke and intracerebral hemorrhage. If it is hemorrhage, then we have to reduce the BP. But if it is ischemic infarct, then if we reduce the BP, then patient will land up in the massive infarct. Because once the artery is occluded, so after the occluded part it is dilated. So for that patient is needs some BP, because BP it's maybe due to chronic hypertension also, and another thing is due to the less availability of blood, automatically our sympathetic system activate and increase the BP also. In those patients, we usually, in ischemic infarct patient, we usually do not reduce the BP unless some clear-cut indication, like in pregnancy patient, preeclampsia, and another thing is like aortic dissection or any cardiac issue like MI or heart failure. In those things, until those things, we have to never reduce the BP. If patient have BP more than 220/110 mmHg, or if patient below 220/110 mmHg. If patient is undergoing the intravenous thrombolysis, in those patients we have to reduce the BP to 180/105 or 110 mmHg. Otherwise, we have to wait, and we have to reduce the BP some 10 to 20% on first 24 hours, and later on we have to reduce some 10% per day. So this is the most common thing, because in periphery when patient get unconscious, his BP is 200 or 230, then everyone gives patient to the mannitol or antihypertensive. When patient reaches to us, he has some 120 130 BP, and his impact is disability is worsens, maximum worsens when compared to the earlier. When he first encountered to the clinic, he has some mild weakness, and later he developed maximum weakness in the affected area. And prevention of complications. So, common complications in this patient, we develop myocardial infarction. This myocardial infarction, this ECG changes may be due to some stroke patient, also due to sympathetic overactivity. Also, ECG shows some MI-like features, or otherwise, my MI patient will develop a stroke also. So these things, and heart failure also. And dysphagia we already discussed, and aspiration pneumonia, these things, and UTI and DVT and PTE. And other thing is dehydration. Fluid is most important in the stroke patient. If we do not hydrate the patient, then patient will get this infarct is again increases, and the disability will worsens. And another thing is pressure source. In this patient, we usually change the posture of the patient or position of patient every second hourly. By that we can prevent the pressure source and other orthopedic complications. If patient chronically more disability develop, then he develops the contractures and this with the intracerebral hemorrhage. Is it okay, or are you people getting any? So I will question. So another thing is intracerebral hemorrhage, which is actually worldwide 80% is ischemic stroke and 20% is intracerebral hemorrhage. This is in developed countries. But in developing countries, like in India, we get this intracerebral hemorrhage is more, like around 30% of intracerebral hemorrhage. So in that most common site, we usually get is putamen and cerebellar region, or cerebral hemisphere, or intraventricular hemorrhage, like that. In this intraventricular hemorrhage is the mortality is the highest than the other region, because of intraventricular hemorrhage leads to hydrocephalus and raised ICP, and leads to the brainstem compression, and patient will land up in these things. So why intracerebral hemorrhage is dangerous? Because case fatality rate in the compared to the ischemic stroke, intracerebral hemorrhage up to 30-40% to up to the 80% based on the which site is intracerebral hemorrhage is located based on that. So that's why intracerebral hemorrhage is the most dangerous, and even we discharge the patient after the 2 to 3 weeks. Then after the we call the patient after 3 or 4 weeks. Then in 50% patients we see we heard the news that patient is died, because intracerebral hemorrhage is more dangerous, because due to that so many complications is developed, and due to that intracerebral hemorrhage is more dangerous compared to the ischemic stroke. So common mechanism is due to the fibrinoid necrosis and lipohyalinosis and cerebral amyloid angiopathy in the older people. So in intracerebral hemorrhage, based on based on the main most commonly is the intracerebral volume. Volume is most important. Based on the volume also we can decide if patient will survive or patient will land up in the other thing. If it is less volume and the GCS score is more than 9, then is probability death by 30 days is less compared to the more than 60 ml of intracerebral volume. So based on this clinically also we can calculate the intracerebral volume based on ABC and by 2 this formula, simplest formula. And because more dangerous of intracerebral is because due to the hematoma expansion, which is maximum in 24 hours, and with maximum expansion is in the first 3 hours. So if we see the patient, we diagnose the patient with intracerebral hemorrhage and we proceed with this management, then there is a prognosis will be better compared to the other thing. So appearance of in intracerebral hemorrhage, most common treatment is BP. BP management is the most common, most important in intracerebral hemorrhage. So based on the few previous trial and latest trial like Interact 2 and ATHAS 2 trial, in all trials, if patient is in intracerebral hemorrhage, a patient having BP around 220 or 150, in between 150 to 220 or more than 220 or around 180 also, in those patients we have to control the BP up to the 140 by, in between 140 to 160 mmHg. This is the most important thing. Due to that, patient will not land up in the expansion of the hematoma and this complication. So this is the BP management based on the BP, and we have to give the oral medications or IV infusion. Mostly in acute setting we used to give the injection form. In that labetalol and hydralazine. Labetalol we usually give the 10 mg IV bolus. Within 10 minutes we repeats every 10 minutes if BP is controlled or not. If BP is not controlled, even after the 3 shots, then we proceed with the infusion of labetalol, some 2 to 8 mg per minute. And even if it is not controlled, then hydralazine or nicardipine or glycerol trinitrate and esmolol. And after the BP control, then maintenance therapy with routine. There is no specific antihypertensive which is better in the stroke patient. Most commonly we use ACE inhibitor or ARBs or calcium channel blockers or diuretics. And nifedipine is commonly seen in this region, but nifedipine is okay, good drug, but due to the nifedipine, patient will land up in the persistent hypotension, and this is a long-term action also. So nifedipine we usually don't use. So in acute setting we use the labetalol or clevidipine or nicardipine, and in long-term basis we usually use the ACE inhibitors, ARBs or and calcium channel blockers. So when patient is come to our clinic, then after NCCT done, then patient have intracerebral hemorrhage or NCCT head. Then we get the question that if it is patient go to the neurophysician or neurosurgeon. This is the common thing. Even in those medical or surgical management is most important, in which if patient is intracerebral hemorrhage, just a small putaminal bleed, or there is no raised ICV features, or even raised ICV features also there is a mild, then usually we treat with the patient with the just medical management, mainly supporting treatment and BP management and with IV fluid. If patient come to the early to the us and with the GCS is less than 9 or even M4 or M5 condition in cerebral bleed, in those patients better we proceed with the surgery with either decompression or evacuation of a hematoma, or if it is intraventricular hemorrhage then evacuation of a hemorrhage. Even post surgery also the in intracerebral hemorrhage there is a prognosis is very bad compared to the ischemic stroke. And in intracerebral hemorrhage, cerebellar hemorrhage is the most important thing, because cerebellum in the posterior calvarium, which is the very less spacious, and around the cerebellum there is a vital centers like our respiratory and cardiac center. So when even some 3 ml of volume of the intracerebral hemorrhage, cerebellar hemorrhage will cause compression the that structure and leads to the respiratory and cardiac arrest chances. So in those patients, if it is patient in procedure comes to the earlier, then we find out the cerebellar bleed, then we proceed with the decompression is the best thing in cerebellar bleed. Even in ventricular hemorrhage is the more worst outcome. If it is in both ventricular hemorrhage, patient will die within 5 to 6 hours. Maximally, we in emergency we usually see the patient with intraventricular hemorrhage, they don't survive. Even up to 80% of mortality is there. So in this, one thing is anticoagulants induce intracerebral hemorrhage. In anticoagulant, usually we routinely use warfarin. And other thing is nowadays newer oral anticoagulants, apixaban, rivaroxaban, these things. In those patients, there is an antidote is available. If it is on history, that is the quick history is important. If patient is taking any blood thinner or like that, if it is patient is taking blood thinner and then rapid test for the look for the INR. If it is in derange in the INR, this thing there, and then we proceed with the fresh frozen plasma, or nowadays in the new medicine like prothrombin complex concentrate. Which is a 4-factor like a 2, 7, 9, 10 these factor agonist. So so in prothrombin concentrate we transfuse the prothrombin concentrate. Then after giving this PCC we look for the INR. If it is INR is normalized, then we can stop the medication because it is very costly. And another thing is DVT prophylaxis based on the stroke. If it is a larger bleed, then we have to wait for based on mild, moderate, or severe stroke. Based on that, we give around 4 days or sometimes more than 8 days. And fever management is most thing. And anti-seizure medication, this is also important. So kindly don't use the multiple anti-seizure medications, because we proceed with the one anti-seizure medication of maximum dose. If it is not responding, then we have to proceed with the another anti-seizure medication. That is better for the patient and in the future is. And based on patient condition, if patient is having ischemic stroke or intracerebral hemorrhage with atherosclerotic etiology, then we proceed with the antiplatelets. In first 21 days, we usually give dual antiplatelets, and after that, we shift to the single antiplatelet. And take-home message. CT scan is the standard care in acute stroke imaging, and in MRI, DWMR is the more sensitive in the hyperacute stage of stroke, and MRI is the better clarify the cerebellar and brainstem function and stroke, mainly brainstem region. So that is the MRI is in those stroke MRI is the main role, and other is and extended window based according to the time mismatch. With that, if any patient present with CT and perfusion or these things, in them we may prevent in mortality and morbidity. And intensive BP control means treatment of spontaneous hypertension to intracerebral hemorrhage, even spontaneous lobar is also. And a few questions.
You are ready for MCQs? Thank you, Dr. Rahul. It was a wonderful lecture and very informative.
Thank you, sir.
And I would like to invite Dr. Rajeev Pandey sir to conduct the quiz session, and we will follow with question and answer after the quiz session.
Most common type of stroke.
You could give the
Ischemic.
options you have? Options?
No option नहीं है sir. That answer. Ischemic, hemorrhagic, or any.
Ischemic.
Ischemic. Okay, sir. 80% is the ischemic stroke, sir. And what is the percentage of ischemic stroke? I have already given answer. Yes sir. In India in India में 69% तक ischemic stroke है. But there is a large studies going on these institutes, PJ Ames. So what is the window period for the thrombolysis?
4.5 hours.
4.5 hours. Okay.
चलिए भाई हाँ बोलिए नेक्स्ट 4.5 hours.
So for window period for the mechanical thrombectomy.
No.
For mechanical thrombectomy 24 hours. Up to 24 hours.
Dr. Ashwini.
And imaging of choice in acute stroke.
CT.
Yeah, this is a basic question. Usually in India like country we usually say the NCCT head. But if it is available in the center and then MRI is the best thing.
So,
but we have to proceed with the NCCT head is the exact. And doses of altiplase and tenecteplase.
0.25 and 0.9.
Which one, ma'am?
Up to ventilator 0.9 and 0.25.
Yes, ma'am. Yes, ma'am.
Maximum 20.
Yes.
Last question.
And most common cause of intracerebral hemorrhage.
Hypertension.
Yeah, yes.
Dr. Girish.
And the most common site of bleed. Last question. Most common site of bleed in hemorrhagic stroke. Most common site.
This will be just a complimentary question because we have only 5 prizes and that has been done.
This is last one question.
This is just a bonus question.
Most common site of bleed in the hemorrhagic stroke.
Thalamus? Insular?
No, sir. Basal ganglia, most common site is putamen. Putamen is most common. Every patient, if we see the CT scan, every patient will get basal ganglia bleed. In that, putamen is the most common site. Okay. Thank you.
Thank you, Dr.
Thank you.
Please, you can have it. Now the session is open for question and answers. If anyone has any question.
What is the role of mannitol in stroke?
Yeah. Mantle we usually use in every intracerebral raised ICP feature patient, no? But unless patient is any kidney problem. In those patients, we usually use with 3% hypertonic saline or diuretics. So mantle is routinely used, ma'am. There is no contradiction with that. Yes. No, that is the one thing, ma'am. Like commonly we see every stroke patient will get mannitol, but in ischemic stroke we shouldn't give mannitol unless it is a large infarct and he developed raised ICP features. So in those patients.
What about the role of steroids in hemorrhagic stroke?
No, there is no role.
Right, left and right.
No, there is no role. Because it will decrease the volume, but after the 24 to 40 hours, patient again may land up in the same condition. There is no role of steroid in this.
Earlier, a lot of people used to give to counteract the cerebral edema.
No, not like that. Not like that. Because a steroid role is like in TB meningitis, like in those patients, they have hydrocephalus, severe hydrocephalus due to the exudate. In those patients who do to decrease the inflammation in that region, we use the steroid. Otherwise, in stroke, there is no role of steroid. Yes.
Why death rate is more common in the interventional hemorrhage?
Sir? For interventricular hemorrhage is also hypertension is one of the cause, but another thing is if it is atypical site, if patient is in basal ganglia region, patient is hypertensive, then there is no role to do anything other. If patient is develop interventricular hemorrhage or cerebellar hemorrhage or cerebral lobar hemorrhage, in those patients we have to proceed with the CT angio plus venography because vascular malformation is we have to rule out vascular malformation.
He's asking that why mortality is more in
because in
intraventricular
hemorrhage sir CSF flow because daily हमारा मतलब brain में क्या है कि 400-500 ml CSF बनता है and at a time 150 ml CSF रहना है हमारा brain में. If it is मतलब interventricular hemorrhage है तो उसमें absorb नहीं होगा, then patient develop hydrocephalus, then brain stem compression and then patient. So interventricular hemorrhage mortality rate is very
Role of
severe.
anti-epileptic antiepileptics in cases of stroke and how long it should be given once it has been started?
No,
Antiepileptics.
antiepileptic, ma'am.
You start, then how long it should be given?
Based on ma'am, if patient there is prophylaxis dose ऐसा तो नहीं है ma'am. Prophylactically we don't use anti-seizure medication unless some patient like lobar infarct, like it is cortical infarct. In those patients they develop the anti-seizure medication. In those patients we used to give if there is a pathology is there. So pathology is there. So in those patients we usually give the up to the 2 years now based on patient condition. If it is a reversible cause, only single seizure, in those patients we usually give up to 3 months. Then we taper within next 10 to 15 days. If it is
there any difference in treatment of cerebral infarct and cerebellar infarct?
no sir, there is no. But usually anti-edema measures not much work in the cerebellar region, sir. In if there is ICT in posterior fossa, there is anti-edema measures are not much work in those patients. There is still debatable that thing. So there is that only. So that's why in those patients there is a mortality rate is very high.
गोरखपुर में कितने मैकेनिकल थ्रोम्बोलिसिस हो रहे हैं इसका?
नहीं सर, that's why I choose this topic. Even thrombolysis भी नहीं हो रहा सर यहाँ. Even thrombolysis भी नहीं हो रहा. Mechanical thrombectomy is another thing. Even thrombolysis भी नहीं हो रहा. So that's why.
कैसे मैनेज कर रहे हैं इसका?
सर अभी हमारे पास अभी जब मेन क्या है कि पेरिफेरी में पेशेंट पेरिफेरी से आता है पेशेंट, सो ऑलरेडी आउट ऑफ विंडो. सो इन दैट पेशेंट का कंडीशन क्या है, मतलब पेशेंट का आया उसका जीसीएस क्या है, मतलब कितना इन्फाक्ट है, कितना बड़ा ब्लीड है, उसके हिसाब से पेशेंट को कंडीशन के बारे में बता देंगे. जस्ट उसके बाद आउट ऑफ विंडो पीरियड तो जस्ट कंजर्वेटिव मैनेजमेंट होनी. पेशेंट यानी अफोर्डेबल पेशेंट इज देयर, देन सिटी एनजीओ में हमको क्लियर कट लार्ज वेसल ऑक्लूजन हो रहा तो उस पेशेंट को हम मतलब हायर सेंटर को भेज देते हैं.
How often you are encountering the cases of MI and stroke together?
Ma'am, MI, one of the most common cause, because in cardioembolic stroke, that is the AF is the most common cause for the stroke. So in these patients, around I think 30-40% patient will get AF, atrial fibrillation. ECG में changes तो आता ही रहता. But even stroke patient में भी ECG में changes दिखता हूँ. Yeah. तो उसमें क्या?
It will be much more confusing whether the
हाँ.
patient is having
So वो patient को हम
MI per se or it is stroke and MI together.
Yeah. मैक्सिमम पेशेंट को कार्डियक इशू होने वाले कोई स्ट्रोक तो रहते हैं ना. एथेरोस्क्लेरोसिस, नेक्स्ट कॉज इज कार्डियक ऑरिजिन, either AF or any thrombus in the this region. So पेशेंट को प्रायर हिस्ट्री नहीं है, नहीं तो पेशेंट पहले पूरा फिट था, तो उन पेशेंट में क्या है कि हम क्या है कि कार्डियक रूल आउट, इसलिए हम इन्वेस्टिगेशन में 2 डे इज मैंडेटरी. इन पेशेंट में कुछ पेशेंट में हमको कुछ एटियालॉजी पता नहीं चलता, उसमें क्या है कि क्रिप्टोजन स्ट्रोक मानते हैं. उन पेशेंट को हम इवन 1 मंथ ELR मतलब वो भी ढालते हैं, मतलब होल्टर मॉनिटरिंग इवन 1 मंथ से भी मॉनिटर करते हैं इन पेशेंट.
Clinically can be diagnosed for that whether it's ischemic or hemorrhagic.
हाँ वही मैम, वही सर स्टार्टिंग में मैं डिस्कस किया था. इसमें क्या है कि हेमरेज स्ट्रोक यूजुअली पेशेंट क्या है कि हाई बीपी रहता है. यूजुअल पेशेंट अबाउट 200 mmHg विद हिस्ट्री ऑफ सडन ऑनसेट विद वॉमिटिंग, हेडेक करके पेशेंट कंप्लीट आता है. एंड अल्टरनेट मेंटल स्टेटस ये ज़्यादा मिलता है इंटरसेट वाले हेमरेज वाले पेशेंट कंपेयर टू इस्केमिक स्ट्रोक वाले पेशेंट.
इस्केमिक में
हाँ ये कम मिलता है. हाँ नहीं बीपी हाई हो सकता सर, बट इतना हाई बीपी नहीं दिखता मैक्सिमम हम पेशेंट. एंड हेडेक वॉमिटिंग्स ये भी कम रहता है इस्केमिक स्ट्रोक पेशेंट.
But sir, you recommended dual antiplatelet therapy.
Yes, ma'am.
But studies have said that dual antiplatelet therapy can convert an ischemic stroke into hemorrhagic stroke.
नहीं ऐसा चांसेस वो भी है मैम, बट इस पे भी स्टडीज है. इसमें आपको रिस्क ऑफ एंटीप्लेटलेट लेने से स्ट्रोक मतलब हेमरेजिक स्ट्रोक नॉर्मल पेशेंट को बता रहा हूँ. नॉर्मल पेशेंट को भी आप एंटीप्लेटलेट लेने से 5 to 10% रिस्क ऑफ ब्लीडिंग हो सकता है. बट इन्फाक्ट में भी हम कौन सा इन्फाक्ट, मतलब स्मॉल इन्फाक्ट है, लार्ज इन्फाक्ट है, उसके ऊपर लार्ज इन्फाक्ट है तो उन पेशेंट में क्या है कि हमको क्या है कि अर्ली स्टेज में हम थोड़ा ड्यूअल एंटीप्लेटलेट नहीं देते, सिंगल एंटीप्लेटलेट पे ढाल देते. उसमें क्या है कि हेमरेजिक ट्रांसफॉर्मेशन चांसेस है, बट हेमरेजिक ट्रांसफॉर्मेशन भी वो विद इन इन्फाक्ट एरिया में ही रहता, तो उससे क्या है कि मास इफेक्ट इतना नहीं आता उसमें. तो उन पेशेंट में हम क्या है कि सिंगल एंटीप्लेटलेट दे दें, मतलब पेशेंट को मतलब एंटीप्लेटलेट पक्का देना है तो. बट लाइक मतलब पेशेंट को सीवियर एथेरोस्क्लेरोसिस है, लार्ज वेसल में एथेरोस्क्लेरोसिस है एंड एनी कार्डियक रीजन उसकी वजह से पेशेंट को चल रहा है, तो उन पेशेंट में हम तो ड्यूअल जगह एंड सिंगल एंटीप्लेटलेट देते हैं. बट अब पेशेंट नॉर्मल कोई भी इवन TIA और स्मॉल इंफ्राक्शन पेशेंट में हम क्या है कि आउट ऑफ विंडो पीरियड है तो ड्यूल एंटीप्लेटलेट्स दे देते, लोडिंग डोज लाइक 300 एस्पिरिन 325, क्लोप्रेडोल 300 mg एंड अटोस्टाटिन 80 mg, फॉलोड बाई हम ड्यूल एंटीप्लेटलेट 75 20 mg विद अटोस्टाटिन एक्स्ट्रा 40 mg or 60 mg फॉर 21 days or in some patient up to the 3 months, followed by we change to either aspirin or clopidogrel.
डॉक्टर साहब कितने TIA के मरीज फर्दर स्ट्रोक में जाते हैं?
हाँ, ये
उसको बचाने के लिए हमको जैसे TIA का केस आया है,
हाँ,
तो हम एक तो CT स्कैन करानी है,
जैसे CT स्कैन में
और
हमको
उसको क्या कर सकते हैं कि वो स्ट्रोक में ना जाए?
हाँ सर, ये कॉमन चीज़ है, हमारी जगह हमको पेशेंट मिल जाता है। TIA पेशेंट को यूजुअली CT में हमको मैक्सिमम कुछ पता नहीं चलता सर। इन पेशेंट में हम MRI करेंगे तो बेटर है। तो इन पेशेंट में हमको भी TIA पहले हम मानेंगे, बट इनमें भी इनफैक्ट हमको मिल जाता है, समलैक्नर स्ट्रोक वैसे मिल जाता है। इन पेशेंट में हम बेटर क्या है कि एंटीप्लेटलेट डाल देना बेटर है। इन पेशेंट में भी हम TIA आया था,
कौन सा एंटीप्लेटलेट?
एंटीप्लेट ड्यूल एंटीप्लेटलेट देते हैं, एस्पिरिन क्लोपिडोग्रेल।
एस्पिरिन
हाँ, 21 days देन सिंगल एंटीप्लेटलेट, इधर क्लोपिडोग्रेल और एस्पिरिन।
सीधी सी बात है कि TIA आई है तो ड्यूल एंटीप्लेटलेट शुरू कर दी।
हाँ, यस
CT में आए चाहे ना आए,
हाँ,
लेकिन इससे बच सकते हैं।
यस।